working in Yusui, which is a rural area in Kagoshima Prefecture. My work mainly involves farm animals. I have been working as a veterinarian for 30 years. But in 2016, I also entered the graduate school to study for PhD. I belong to the domestic animal internal medicine laboratory at Kagoshima University. Today, I will talk to you about my study titled Pharmacokinetics of enrofloxacin in the peripheral blood and bronchoalveolar region after single subcutaneous administration in calves. I have changed the title since making the abstract. I am showing you the new title in this presentation. Calf bacterial pneumonia and mycoplasmal pneumonia adversely affect development and life expectancy, and these infectious diseases are major challenge for veterinarians. Many cases are classified as alveolar pneumonia and so should be treated with antimicrobial agent that leads to the bronchoalveolar region. However, a number of antimicrobial agents do not reach the bronchoalveolar region, or not enough of the drug reaches this region. So, veterinarians need to select an antibacterial agent with good distribution to the bronchoalveolar region when treating calf pneumonia. Enrofloxacin is a quinolone-based agent with a broad spectrum of antimicrobial activity and widely reported distribution to many bovine tissues. It is known to reach a minimal inhibitory concentration, MIC, in pulmonary tissues. However, this is little published on whether it reaches the bronchoalveolar region. The barrier between the body and the outside environment. Accordingly, in this study, we investigated the transition in bronchoalveolar enrofloxacin concentration in calves over time through analysis of bronchoalveolar fluid. This slide shows our method. We use 4 clinically healthy male Holstein calves. Each calf received 2 single subcutaneous doses of 5 injectable solution or high-dose injectable solution. Blood and BALF samples were collected pre- and post-administration, and we measured the concentration of enrofloxacin, its metabolites, ciprofloxacin, and urea nitrogen. This slide shows detail on BALF and blood sampling. Blood and drawn by the jugular vein, and BALF was collected before and after administration, as shown here. BALF was centrifuged to separate the supernatant and cell pellet. We performed bronchoalveolar lavage to collect the BALFs using an endoscope, as shown in this slide. We selected 6 BALF collection sites at each administration, 3 sites per lung, left and right. The sites were selected at random, and we used different sites at the first and second administration in each calf. Each BALF sample was quantified and then centrifuged. The BALF recovery rate was calculated as the proportion of the injected amount, 30 milliliters, in the collected amount. The BALF cellular fraction was analyzed for enrofloxacin drug and ciprofloxacin metabolite, and the BALF supernatant was analyzed for urea as well as the drug and metabolite. Plasma and BALF supernatant urea concentration were measured with a bioassay method. Plasma BALF supernatant and BALF cellular fraction drug and metabolite concentration were measured with HPLC. Pulmonary ERF drug and metabolite concentration were calculated based on plasma and BALF supernatant urea concentration with the formula shown here. This slide shows PK results at 5 milligrams per kilograms. The blue line shows the drug concentration, and the red line shows the metabolite concentration over time from the administration in the 3 matrix. As you can see, the drug and metabolite concentration reach a maximum at around 2 and 6 hours, respectively in plasma and ERF, and at around 6 hours in BALF cell. This slide shows the PK results at 7.5 milligrams. As in the previous slide, the blue line is for the drug, and the red line is for the metabolite. Here, the drug and metabolite concentration reach a maximum at 6 to 10 hours in each matrix. This slide shows PK results for the drug and metabolite combined. On this slide, the red line shows the result at 5 milligrams. And the blue line shows the result at 7.5 milligrams. The combined maximum concentration was higher and later at the high dose in each matrix. We compared exposure between the 2 doses based on the area under the time combined drug plus metabolite concentration curve. You can see the actual figure on this slide, but bronchoalveolar region AUCs were about 4.6-fold greater than the plasma AUC at 5 milligrams per kilograms, and around 8.9-fold greater than the plasma AUC at 7.5 milligrams per kilogram. These results for AUC shows that exposure was particularly high in the bronchoalveolar region, much higher than in peripheral blood. Enrofloxacin reported has a 90% minimal inhibitory concentration, MIC 90, of 0.25 microgram per milliliters for Mycoplasma bovis and Myhemia hemolytica, and 0.031 microgram per milliliters for Pastilla multicida. And its effect is related to the Cmax to MIC and AUC to MIC ratios. The recommendation for antibiotics in veterinary medicine in Cmax to MIC ratio at least 10, and an AUC to MIC ratio of at least 125. We found that Cmax to MIC and AUC to MIC ratios were low in blood, but high in the bronchoalveolar region. And so we regard enrofloxacin as a clinically active antibacterial agent in the bronchoalveolar region. Based on results of this study, subcutaneous enrofloxacin reaches the bronchoalveolar region at a sufficiently high concentration in calves. We demonstrated it has better distribution to the bronchoalveolar region than blood. The Cmax and 0 to 24 hours AUC in the bronchoalveolar region were remarkably high, suggesting this agent is effective against pneumonia when administered subcutaneously. The next step in our research is analyze the pharmacokinetics of enrofloxacin in BALF cases of bovine pneumonia. Our research is supported by Buiatrics Ltd. That is the end of my presentation. Thank you very much for your attention.